background. All right, so this morning we're gonna finish up the neonate head. So we're gonna get into pathology now. Just gonna switch over to the PowerPoint. So one of the most common disorders for the neonate brain that we do these neonate head ultrasounds for is to rule out ventriculomegaly or hydrocephalus. So these two terms can be used interchangeable: hydrocephalus or ventriculomegaly. So ventriculomegaly is the most common disorder of the neonate brain and is marked by dilatation of the ventricular system. Ventricular enlargement may be caused by a variety of conditions, leading to obstruction, overproduction, or decreased absorption or reabsorption of cerebrospinal fluid. So again, ventriculomegaly or hydrocephalus can be caused by either an obstruction, overproduction of cerebrospinal fluid, or decreased reabsorption of cerebrospinal fluid. With hydrocephalus, neonates may be diagnosed with ventriculomegaly or hydrocephalus in utero, or may present clinically with a bulging anterior fontanelle or macrocephaly, so an enlarged head. So if it's not diagnosed in utero, they may notice that the anterior fontanelle starts to bulge, or the baby's head circumference is abnormally large at the time of birth. However, initial ventricular dilatation occurs without change in head circumference, and hydrocephalus may be silent because the white matter of newborn brains is very compliant and easily compressed as the ventricles widen. So you may not necessarily see, any telltale signs of hydrocephalus because the forming brain, the white matter is very soft, very spongy. So that's able to accommodate or compliant to the expanding ventricles. So that white matter gets compressed before you may see, you may have significant compression of the white matter before you actually see any telltale signs of a hydrocephalus. Results from an imbalance between production of, it can also result from imbalance between production of cerebrospinal fluid and its drainage by the arachnoid villi. So the three mechanisms for development of hydrocephalus, again, is going to be either an obstruction to outflow, decreased absorption, or overproduction of cerebrospinal fluid. So those are going to be your three mechanisms for development of hydrocephalus. So hydrocephalus may be acquired, or it could be a result of a congenital malformation. Acquired hydrocephalus may result from cerebrospinal fluid obstruction from an intracranial hemorrhage. This is also known as post-hemorrhagic hydrocephalus. When severe dilatation occurs, or after the loss of deep white matter in periventricular leukomalacia. So congenital hydrocephalus occurs before birth. It may be due to structural malformations or congenital brain infections. In general, the earlier the hydrocephalus occurs in utero, the greater the enlargement of the neonate head. Congenital hydrocephalus. So hydrocephalus refers to any condition in which enlargement of the ventricular system is caused by imbalance between production and reabsorption of cerebrospinal fluid. Some sonographic findings. So you have blunting of the lateral angles of the lateral ventricles. Infants born with ventricular enlargement are considered to have congenital hydrocephalus. Excessive fluid production may occur in infants with papilloma of choroid plexus, a tumor that actively secretes cerebrospinal fluid. So this papilloma in the choroid plexus can actively secrete excess cerebrospinal fluid. Two anatomic types of hydrocephalus. There are two anatomic types of hydrocephalus. So either obstructive or communicating. Obstructive hydrocephalus. So this is characterized by interference of circulation of cerebrospinal fluid within the ventricular system itself, and which leads to subsequent enlargement of the ventricular cavities due to proximal to the obstruction. So divided into communicating and non-communicating forms. The latter is referred to as obstructive hydrocephalus and is characterized by blockage of cerebrospinal fluid anywhere within the ventricular system itself, causing subsequent enlargement of ventricular cavities proximal to the obstruction. The most common cause of both acquired and congenital hydrocephalus is aqueductal stenosis. So a common location is going to be the aqueduct of Sylvius, which is situated in the midbrain and is narrowed or replaced by multiple small channels with blind ends. So communicating hydrocephalus. So with communicating hydrocephalus, cerebrospinal fluid pathways are open within the ventricular system, but there is decreased absorption of cerebrospinal fluid. Absorption of cerebrospinal fluid can be impeded by occlusion of subarachnoid cisterns in the posterior fossa, or by obliteration of subarachnoid spaces over convexities of the brain. Entire ventricular system becomes uniformly distended. So if it's an issue with decreased reabsorption of cerebrospinal fluid, you'll see the entire ventricular system dilated. Whereas if it's an issue with stenosis or blockage in one of the aqueductal channels, it's going to be the proximal ventricles before the stenosis that become dilated. So again, the most common cause of congenital hydrocephalus is aqueductal stenosis. So aqueduct of Sylvius is either narrowed or replaced by multiple small channels with blind ends. Maybe also be caused by extrinsic lesions posterior to the brainstem, such as a congenital aneurysm of the vein of Galen. Sorry, I apologize. So hydrocephalus or ventriculomegaly will lead to increased intracranial pressure. So development of increased intracranial pressure, which is the cause of or result of brain injury. Increased intracranial pressure restricts cerebral blood flow and is a serious medical condition. So there's a way for us to go back. Sorry. So there's a way for us to detect this increased intracranial pressure. We'll get into in a minute. We actually do a Doppler tracing of the middle cerebral artery. So ventricular measurements. So if we see dilated ventricles, we're going to want to measure them. So there's 3 measurements that are commonly done to measure hydrocephalus. Your 3 measurements that they typically use are going to be your ventricular index or VI, the anterior horn width, and the thalamo-occipital distance. So your ventricular index or your anterior horn width are taken at the level of the 3rd ventricle in a coronal view. The VI is measured at the widest point to the falx, and the anterior horn width is measured at a diagonal at the widest point. The thalamo-occipital diameter is taken from the parasagittal view and is measured from the outermost part of the occipital horn to the junction of the choroid with the outermost part of the thalamus. So this shows your anterior horn width and ventricular index. So we're going to measure the middle. And then your thalamo-occipital diameter. So here's your thalamus, your choroid plexus. So you're going to go from the border of the choroid plexus and thalamus, measure out maximal distance to the occipital region of the brain. So this is going to be in your sagittal view. This is going to be in your coronal view. So ventricular index is the most commonly utilized metric and shows a considerable increase with maturation. Anterior horn width, regardless of gestational age, over 4 millimeters may indicate dilatation. With preterm infants with a thalamo-occipital diameter measurement over 19 millimeters or 1.9 centimeters, and term infants with a thalamo-occipital diameter over 21 millimeters may also indicate ventricular dilatation. So hemodynamic changes may be recorded by spectral Doppler and utilized to identify infants with elevated intracerebral pressures or intracranial pressures. A tracing from the pericallosal artery is obtained from the anterior fontanelle. If reversal flow already exists, then this is an indication of increased intracranial pressure, and the fontanelle pressure is not recommended. If no reversal is detected, then pressure is applied to the anterior fontanelle. So you're going to have your sagittal view at your choroid plexus here. So you're going to be midline. You're going to have the artery coming up towards you. So you place your Doppler right in the middle of the artery. So this is without compression or without pressure. You could see that we have a diastolic flow reversal. So again, if we think back to our transcranial Doppler, this is a brain artery. We should have nice low resistant arterial waveform. So this is flow reversal. So this is going to be a very high resistant waveform. So this will indicate increased intracranial pressures. So in this instance, we don't have to apply gentle pressure over on the anterior fontanelle. So this is another example. Again, you could see, dilatation of choroid plexus here. So we get our Doppler tracing during relaxed, then we apply some compression, some slight compression to the anterior fontanelle while we're Dopplering. And when we apply compression, we get reduction of the diastolic flow, reduction of the waveform. So this also will indicate increased intracranial pressures. So if it was a normal baby and there was no evidence of increased intracranial pressure, the brain is able to comply to that slight pressure that we apply to the anterior fontanelle, and we won't see a reduction in diastolic flow or reduction in systolic flow. Then when we release, we see a resumption of what appears to be our normal arterial intracranial waveform. So basically, this is showing that the brain isn't able to accommodate increase or extra pressure. So the brain is not compliant. So the pressures are already elevated or maxed out. So measurements continued. So sonographer should also look for blunting of the lateral angles of the lateral ventricles. So you could see that these angles become blunted. They're not sharp. So you get rounding of the lateral angles. So the ventricles become rounded or blunted. So you don't have the nice, sharp, crisp angles that you would normally see in your lateral ventricles. So we can also encounter, in addition to hydrocephalus, extra axial fluid. So it is hypothesized that immature arachnoid granulations in infancy may cause cerebral spinal fluid to accumulate in subarachnoid spaces. The arachnoid granulations only form at birth and develop until 18 months. So this is before birth. Lymphatic pathways are utilized. This drainage also continues throughout the neonatal period. So extraaxial fluid. So over here, we could see this is going to be our coronal view again. So this is going to be our extraaxial space. If cortical ventricles are seen passing through the superficial fluid, this is also known as a cerebral cortical vein sign. It suggests a collection of the subarachnoid. So if cortical vessels are seen passing through the superficial fluid, this is known as the cerebral cortical vein sign and suggests that the collection is subarachnoid. So you can see these vessels when we put color on, coursing through. This is our sagittal sinus. Acquired brain lesions and intracranial hemorrhage. So the premature neonate is at the greatest risk for intracranial hemorrhage, and it is a major cause of mortality and morbidity, or even cerebral palsy in this population. So acquired brain lesions or intracranial hemorrhage. Intracranial hemorrhages, or also more specifically termed germinal matrix intraventricular hemorrhages, are the most common hemorrhagic lesion in preterm neonates. That's going to be one of your major indications in the NICU for premature babies, is to rule out these germinal matrix bleeds, these intraventricular hemorrhages. So they affect 40 to 70% of infants less than 30 to 34 weeks of gestation. So you can see that's a pretty high incidence when you're talking about a premature infant, up to 70%, with an increased risk in infants less than 32 weeks gestation or a birth weight of less than 1.5 kilograms or 1,500 grams. So germinal matrix intraventricular hemorrhages are a developmental disease as they originate in the, as they originate in the sub and sub and ependymal analysis. Ependymal germinal matrix. Apologize. While hemorrhage begins there, it can spread throughout the ventricular system and at worst case into the parenchyma. I'm going to show you in a minute where these bleeds originate, and as you have different grades and severities of intracranial hemorrhage, it can penetrate into the parenchyma. So another important thing to remember is that acute hemorrhage will appear echogenic. And as the hemorrhage ages, it starts to become anechoic. So acute new hemorrhage is echogenic, and chronic hemorrhage appears more anechoic. So subependymal hemorrhage, usually seen at the thalamic caudate notch, is a very echogenic lesion pushing up the floor and the external wall of the lateral ventricle with partial obliteration of ventricular cavity. Can extend by continuous bleeding and perforate ventricular wall with partial or total flooding of the ventricular system. So we have different grades that we use to classify a germinal matrix bleed. So we have from grade 1 to grade 4. Grade 1s can be sometimes very tricky or difficult, to diagnose or even observe. Grades 2, 3, and 4 are definitely more noticeable, and grades 3 and 4 will be completely obvious to you. So don't beat yourself up too much if if there's a grade 1 bleed that you may not necessarily see. So that's why the radiologist, will review your images very carefully and make that diagnosis, of a grade 1 bleed. And that's also a reason why we do follow up in serial ultrasounds. So usually these ultrasounds are performed 7 days after birth, because it takes a while, it takes a little bit for these bleeds to start to develop. So ventricular size. So we can have mild dilatation of the ventricles, 8 to 10 millimeters, moderate dilatation, 11 to 14 millimeters. Could be accompanied by severe dilatation, greater than 14 millimeters. So grade 1 germinal matrix bleed. So the subependymal hemorrhages are caused by capillary bleeding in the germinal matrix. The germinal matrix is the tissue of neurons and glia cells that develop before migrating from the subventricular subependymal region to the cortex. And the most frequent location is at the caudothalamic groove. So this is going to be our sagittal view. This is our lateral ventricle. So over here is going to be our caudothalamic groove. So you can see a grade 1 may be kind of hard to recognize. So it's this little echogenic area that we see developing. So over here is choroid plexus. So you can see choroid plexus looks pretty similar to a developing bleed. So you could see it over here in our coronal view, this echogenic developing. So you can see grade 1 bleeds are pretty hard to recognize and may not be necessarily obvious. So subependymal cysts, these are most commonly the result of the sequela of a germinal matrix hemorrhage in premature infants. These present as discrete cysts in the lining of the ventricles and are seen as smooth-walled spherical cysts in the lateral ventricle at the caudothalamic groove, whereas a clot where there was a clot previously. So if you go back to your views here, you may see a small cystic structure, a small thin wall cyst appearing in the area of that caudothalamic groove, which may represent a previous grade 1 germinal matrix bleed as a sequela of the bleed. So grade 2 and grade 3 intraventricular hemorrhage. So germinal matrix or subependymal hemorrhage can extend by continuous bleeding and perforate the ventricular wall with partial or total flooding of the ventricular system. So these are bleeds that actually penetrate into the ventricles. So whereas these bleeds, they just, I guess, push against the ventricles. This other bleeds will actually penetrate through this layer and involute and penetrate into the actual ventricular space itself. So grade 2 and grade 3 intraventricular hemorrhages are not a sudden event and usually expand slowly. Typically, when a small germinal matrix bleed progresses to a large intraventricular hemorrhage, it's usually during the first 4 days postpartum. And intraventricular hemorrhages are asymptomatic. In some infants, germinal matrix intraventricular hemorrhage can extend very fast. Sudden flooding and distension of ventricles by hemorrhage is associated with clinical symptoms of shock, seizure, hypoxemia, and a sudden decrease in hematocrit. So you may get an order for, a stat neonate head scan. If the baby all of a sudden, starts destatting, their O2 stats start lowering, if they start developing seizures or symptoms of shock, if there's sudden drop in their hemoglobin and hematocrit. So they'll order a stat exam. I know in the hospital, sometimes they'll order a stat, when it's not necessarily, a super stat thing. Because typically these bleeds are a very slow process. But if the baby has a sudden, change in, symptoms, then it could be, a very fast bleed, and then that truly is going to be a stat exam. So if the baby's stable, there hasn't been any changes, and they're ordering it stat, and they want you to do it in the middle of the night, try and convince them to wait off. Tell them, our pediatric attending isn't in. You're not going to get an official read on this till the morning when the pediatric attending comes in. Can this really wait till the morning? If you're not very versed or comfortable in doing these head ultrasounds. If the baby's stable and there's no dramatic changes, typically you can wait. Whereas if the baby has a sudden, change in status, then it is truly a stat exam, and you should go down there and at least attempt it and take pictures. So grade 2 and grade 3. Again, acute bleeds will appear echogenic. So as the intraventricular hemorrhage appears echogenic, structures inside the anechoic ventricular cavities. So this hemorrhages and appears echogenic structures inside the ventricular cavities, which are anechoic. Blood may fill just a small portion of the ventricle or the entire cavity. So here you have your coronal view. You could see echogenic here, starting to fill the cavity. This looks like a portion of the choroid plexus coming in. So here, again, you see echogenic coming in, filling the cavity. So intraventricular hemorrhage appears echogenic, structures inside the anechoic cavity. So these are, again, some more pictures. Your sagittal view and your coronal view. It's going to be your lateral ventricle. See echogenic material filling into the occipital horn, extending back into the lateral horn. I'm sorry, occipital horn, lateral horn, or temporal horn. I apologize, temporal horn, occipital horn, and interior horn. So grade 4 bleed. So this is when the hemorrhage penetrates through the ventricles and now is entering the parenchyma of the brain. So this is a severe complication, indicates that the brain parenchyma has been destroyed. So primary infarct of periventricular and subcortical white matter with destruction of lateral wall of the ventricle. When necrotic tissue liquefies, the intraventricular hemorrhage extends into the necrotic areas. So basically what's going on is that hemorrhage has become large and it's increased the pressure and it's pushing on the ventricles, and there's now destruction of the white matter. So the white matter, the vessels are becoming compressed. You're not getting blood flow. So you're getting destruction and necrosis of that white matter. And that white matter then becomes necrotic and starts to liquefy, and the walls break down and the hemorrhage extends into those necrotic areas. So sonographic appearance appears as very echogenic zones within the white matter adjacent to the lateral ventricles. Echogenic areas in the white matter may correspond to IPHs or to intrahemorrhagic infarcts or extensive periventricular leukomalacia. So classic grade 4 intraparenchymal hemorrhage. You'll see clot extending from the white matter into the ventricular cavity. So you can see over here, this very echogenic areas within the white matter of the brain. So here you can see the ventricles, hemorrhage within the ventricles, which is now broken down the walls of the ventricles and it's extending into the brain, into the matter of the brain. So this is going to eventually, liquefy and break down and start appearing anechoic as that tissue starts breaking down. So 4 categories of intracerebellar hemorrhage. So the primary intracerebellar hemorrhage. There's venous infarction. There's traumatic laceration resulting from occipital diastasis. Extension to the cerebellum of large SC intracerebral SCH intraventricular hemorrhage. Epidural hemorrhages and subdural collections. So you can also have epidural hemorrhages and subdural fluid collections. These are better diagnosed with MR or CT because lesions are located peripherally along the surface of the brain and not often adequately visualized by ultrasound. So extracorporeal membrane oxygenation. So neonatal ultrasound is primarily used to monitor hemorrhage in the brain tissue of infants on extracorporeal membrane oxygenation or ECMO. So ECMO is used for pulmonary and circulatory support in many neonatal conditions to allow additional time for the lungs to develop. So these ECMO machines are basically designed to take stress off the heart and the lungs and allow the lungs to develop. Infants born with diaphragmatic hernia, persistent pulmonary hypertension, meconium aspiration, and congenital heart disease may be recommended for ECMO to give the infant's lungs a chance to mature. So ischemic hypoxic lesions. So ischemic hypoxic cerebral injury is a frequent complication of sick newborn infants. Hypoxia is the lack of adequate oxygen to the brain. Ischemia is the lack of adequate blood flow to the brain. So don't confuse the two terms. Hypoxia is lack of oxygen. Ischemia is lack of adequate blood flow. So these can result from a variety of insults like respiratory failure, congenital heart diseases, and sepsis. So there are 5 major types of neonatal hypoxic ischemic brain injury. There can be selective neural necrosis, status marmoritis, parasagittal cerebral injury. We can have periventricular leukomalacia, or also called white matter necrosis, or focal brain necrosis. In ischemic hypoxic encephalopathy, sonography may show areas of increased echogenicity in the subcortical and deep white matter in the basal ganglia. So with periventricular leukomalacia, this is the chronic stage of white matter necrosis, is identified with sonography when echolucency develops within the echogenic white matter. So echolucence, so that's going to be, you're going to start developing anechoic areas within the echogenic white matter. So the presence of echolucence, so the prima facie evidence that necrotic injury exists in the cerebral white matter. So with periventricular malacia, you start developing some echogenic areas within the white matter. The echogenic areas will continue to spread. So this is hemorrhage in the white matter. So if necrosis is persistent in the echogenic areas, cavitary lesions appear two or more weeks after the ischemic insult. Therefore, careful follow-up studies are required. Chronic stages and definitive diagnosis of periventricular leukomalacia with sonography when echolucence develop in echogenic white matter. So you can see here continuation, development of the echolucence. So if necrosis is present in the echogenic areas, cavitary lesions appear 2 or more weeks after ischemic insult. Therefore, careful follow-up studies are required. So chronic stage and definitive diagnosis of periventricular leukomalacia with sonography when echolucence develops within the echogenic white matter. So focal brain necrosis, these necrotic lesions occur within the distribution of large arteries. This complication is present in term and preterm infants, but is infrequent under 30 weeks of gestational age. Ventricular maldevelopment, asphyxia or hypoxia embolism from the placenta, infectious diseases, or thromboembolism secondary to disseminated intravascular coagulation or polycythemia have been implicated as causal factors in this condition of focal brain necrosis. The term proencephaly is used to describe a single cavity. Multicystic encephalomalacia for multiple cavities, and hydrancephaly for a large single cavity with the entire disappearance of the cerebral hemispheres. Ultrasound images of these injuries show very echogenic localized lesions within the distribution of the major vessel. Echodense lesions are considered to correspond to cerebral infarcts. After several days, somnolucence appear within the echogenic areas. So ventriculocystrate, vasculopathy, LVS, may be seen in neonates with IHII. Is characterized by linear echogenic foci branching within the basal ganglion and thalamus. These lesions have been associated with HII in neonate. So you can also have congenital brain malformations. There are a number of different malformations may occur in the fetal brain development and may be related to neural tube closure, diverticulations, vessel formation, or neural tissue migration, including sulci development. So neural defects. Some of the more common ones is going to be your Chiari malformations. So these are congenital anomaly associated with spina bifida. The cerebellum and brainstem are pulled towards the spinal cord. Secondary hydrocephalus develops. So Chiari 1, there's a downward displacement of cerebellar tonsils without displacement of the fourth ventricle or medulla. Chiari 2, which is the most common and of the greatest clinical importance because of its association with the meningocele. You can also have a Chiari 3 malformation. This is a high cervical encephalommeningocele in the medulla, fourth ventricle, and the cerebellum, in which the medulla, fourth ventricle, and cerebellum reside. So sonographic findings. So there's failure in neural tube closure results in a small posterior fossa. The myelomeningocele may develop as a result of open neural tube defect. The myelomeningocele decompresses ventricles, causing underdevelopment of the posterior fossa. So sagittal studies of through the anterior fontanelle show a small cerebellum, absence of the cisterna magnum, low position of the fourth ventricle. You also see displacement of the cerebellum through the foramen magnum associated from hydrocephalus, absence of the septum pellucidum, as well as widening of the third ventricle. Another condition could be agenesis of the corpus callosum. So hypoplasia or agenesis of corpus callosum may occur during process of ventricular induction, ventricle induction, or cellular migration. It's often combined with migration disorders such as heterotopias or polymicrogyria, sorry. Absence of the corpus callosum may also be induced by ischemic lesions in the midline or by intrauterine encephalomalacia. Other associated defects include proencephaly, hydrocephalus, microgyria, and infusion of hemispheres. Corpus callosum is also absent in severe holoprosencephaly. Agenesis of corpus callosum may be associated with Arnold-Chiari malformation and hydrocephalus. In neonates with this anomaly, the cerebral hemispheres have ventricles with pointed upper corners. So this is considered what's called a bat wing appearance. So you'll have narrow frontal horns and marked separation of the anterior horns and bodies of the lateral ventricles associated with widening of the occipital horns and third ventricles. So ventricular cavities acquire a distinctive appearance of a vampire bat wings. characteristics easily identified with sonography. Partial agenesis of corpus callosum occurs when the genu, splenium, and rostrum are absent. So here you can see very narrow lateral ventricles. And wider occipital. So you get narrowing of your lateral ventricles, and particularly the anterior horn of the lateral ventricle, and then widening when you get into the occipital portion of it. Another malformation is Dandy Walker malformation. So again, this is a congenital anomaly. You wind up with a very large fourth ventricular, a huge fourth ventricle cyst, occupies areas where the cerebellum usually lies. Secondary dilatation of the third and lateral ventricles will occur. So you have your large cystic structure in the area of the fourth ventricle, which causes obstruction for your aqueduct and will result in more proximal dilatation in your third ventricle as well as the lateral ventricles. So this is going to be through your mastoid view. So you can see here you have your cystic structure. It's your cerebellum. Your horns are your cerebellum. So you have displacement of the cerebellum, dilatation of the third ventricle. These are going to be your occipital horns for your lateral ventricle. So then we could also have you can also have disorders of the diverticulum and cleavage. So with holoprosencephaly, this is complex developmental abnormality of the brain arising from failure of cleavage of the prosencephalon. Failure results very early in gestation. It's characterized by grossly abnormal brain in which there is a common large central ventricle. Abnormalities found in holoprosencephaly include cyclopia, cerebrocephaly, ethmocephaly, median cleft, and holotelencephaly. So holoprosencephaly represents a spectrum of malformations. It could be alobar, semilobar, lobar, subtopic dysplasia. Neuropathologic features. There's a single cerebrum with single ventricular cavity. Absence of the corpus callosum and frontal horns. A thin membrane arising from the roof of the third ventricle may extend posteriorly, forming a supratentorial cyst. Anomalies of the face also accompany this condition. So again, that's going to be midline anomalies like, cleft lip, cleft palate, the cyclopia. You can see a large single ventricle here. So a lobar prosencephaly, this is the most severe form. It's accompanied by multiple facial anomalies. Sebocephaly, cyclopia, ethmocephaly. Brain surrounds a single midline crescent-shaped ventricle with a thin, primitive cerebral cortex and surrounding large ventricle. You can also have semilobar holoprosencephaly. So with this, we have a single ventricle, more brain parenchyma is present. There's a small portion of falx and interhemispheric fissure develops in the occipital cortex posteriorly. May separate occipital and temporal horns. The splenium and the genu of the corpus callosum often formed, but may be seen on midline sagittal images. Thalmi is partially separated and with a rudimentary third ventricle. Mild facial anomalies like hypotelorism and cleft lip may be present. Hypotelorism. Lobar holoprosencephaly. This is going to be the least severe form. There's nearly complete separation of the hemispheres with development of the falx and interhemispheric fissures. There can also be possible fusion of the frontal horns. Septum pellucum is absent. Anterior horns of the lateral ventricles are fused, but the occipital horns are separated. Third ventricle is present and separates thalmi. The splenium and the body of the corpus callosum present with absence of genu and rostrum. These are just some pictures for the lobar holoprosencephaly. So we see a fused anterior horn here. But we're able to see a separation in the occipital horn. Destructive brain lesions. So this is hydranencephaly. Results in bilateral occlusion of internal carotid arteries during fetal development. So this is a result of bilateral occlusion of the internal carotid arteries during fetal development. The brain is destroyed and replaced by cerebral spinal fluid. Hydranencephaly. The posterior communicating arteries posterior communicating arteries preserved, midbrain and cerebellum is present. The basal ganglia, choroid plexus, and thalamus may also be spared. Sonographic findings, absence of normal brain tissue with almost complete replacement by cerebral spinal fluid. The flux is absent or partially absent. Presence of midbrain, basal ganglion, and cerebellum. Microcephaly may also be present. And color flow absent in the carotid arteries. So with this baby, I actually had one of these where I put the probe down and I'm like, all right, where's the brain? Because essentially there is no brain. You're just basically left with just, the vital portions of the brain stem, which are responsible for your respiration, your heart rate. You also have a portion of the cerebellum back here. So you get your brain stem, but you have basically, agenesis of your cerebrum. And it's all just cerebral spinal fluid in there. This looks like a piece of the thalamus. So again, other destructive lesions. So porencephalitic cysts, cysts filled with cerebral spinal fluid that communicate with ventricular system or subarachnoid space. So these cysts may result from hemorrhage, infarction, delivery trauma, or inflammatory changes in the nervous system. Affected brain parenchyma undergoes necrosis, and brain tissue is reabsorbed, and the cystic lesion remains. So cysts seen within brain parenchyma without mass effect. So mass effect means that the cyst distorts or shifts the brain parenchyma. So it's seen without that distortion of the brain parenchyma. Maybe communication of cyst with ventricle or subarachnoid space. There may also be reduction in size of affected hemisphere, may cause midline shift or contralateral ventricular enlargement. You can also have you can also have a choroid plexus cyst. So a choroid plexus cyst versus the subependymal cyst. So choroid plexus cyst versus subependymal cysts. Choroid plexus cysts are common, tend to be singular and present as an isolated finding, and is not associated with other cerebral congenital neurological defects or chromosomal abnormalities. When cysts are greater than 10 millimeters and multiple, so this could be can be associated with chromosomal abnormalities, particularly trisomy 18. Choroid plexus cyst appears a well-defined anechoic mass within the dorsal choroid plexus and range in size from 4 to 7 millimeters, usually unilateral with left larger than right. It's here over here, choroid plexus cyst. Uh, Galenic venous malformation. So this is a dilation of the vein of Galen caused by vascular malformation, fed by large arteries off anterior or posterior cerebral artery circulation. Infants usually present with congestive heart failure. So on sonography, this is seen as an anechoic cystic mass between the lateral ventricles. It lies posterior to the foramen of Monro and superior to the third ventricle, primarily midline. It can be seen with large feeding vessels. So again, you may also have hydrocephalus present, so dilatation of the ventricles as a result of extrinsic compression from that large vessel. Calcifications may also occur, especially if thrombosis is in the malformation. See this very large vascular structure, large dilatation of the vein, filling with flow. There may also be thrombus present within that vein. Another condition that we may encounter are arachnoid cysts. Arachnoid cysts are lined by arachnoid tissue and contains cerebrospinal fluid and may arise within one of three meninges and arise with any of the three meninges. There are three major causes postulated to explain the formation of these cysts. One is localized entrapment of fluid during embryogenesis. Second could be residual subdural hematoma. The third potential cause that could be is fluid extravasation secondary to a leptomeningeal tear or a ventricular rupture. So arachnoid cysts usually appear on sonography as a sonolucent structure arising from the quadriminal plate cistern or the suprasellar region. Color Doppler may be used to verify that these are not venous malformations, especially when cysts occur within the quadriminal plate cistern or the suprasellar region. So, brain infections. Most frequent congenital infections are commonly referred to by the acronym TORCH. So your TORCH viruses are going to be your Toxoplasma gondii, rubella virus, cytomegalovirus, herpes simplex 2, and the O stands for other. So that could be namely syphilis, which may cause acute meningitis. So these viruses, have an impact on brain development, attack the brain. Brain infections, sonography may detect parenchymal calcifications or matriculocystrate vasculopathy. Other complications that may arise include hydrocephalus, abscess formation, white matter softening, encephalomalacia. and their infarctions. So you can see these echogenic areas developing within the white matter. Sorry. Sorry. You can also have ventriculitis. So ventriculitis is a common complication of purulent meningitis in newborn infants, probably caused by hematogenesis spread of infection to the choroid plexus. Presence of foreign body in ventricular cavity may provide nidus for persistent infection of ventricular cavities. So, so if this patient had, like hydrocephalus, and they had catheter draining the cerebrospinal fluid to take pressure off the brain, if they had a shunt or a stent in, that stent may provide a surface for persistent infection, which can lead to infection of ventricular cavities. Sonographic finding leads to compartmentalization of ventricular cavities by inflammatory adhesions extending from wall to wall. First stage is seen as very thin septations extending from the walls of the lateral ventricles. Septi become thicker and lead to multilocular hydrocephalus and extensive disorganization of brain anatomy. Sequential studies in patients with meningitis or ventriculoperitoneal shunts can provide early diagnosis of this severe complication. Ependymitis occurs when the ependyma becomes thickened and hyperechoic. This results in irritation from hemorrhage within the ventricle. More common and occurs earlier than ventriculitis, developing from intraventricular hemorrhage. So the good thing when you're doing these ultrasounds is that a lot of these conditions you're not going to have to really diagnose or come up with. I mean, basically the radiologist is relying on you to decide, is there hydrocephalus, is there ventriculomegaly, are the ventricles dilated, and if so, take your measurements, and also basically diagnosing large bleeds. So these grade 1 bleeds, that we said can be sometimes difficult to see. That's really up to the radiologist, to diagnose those. You're going to be getting sweeps. I know my one lab liked us to do cine clips. So you're just sweeping, through your angles. So in coronal view, you're coming all the way anterior to where you see the orbits, and you're sweeping all the way posterior, until you see the cerebellum coming in, and the hindbrain. So you're getting sweeps, you know, through the entire brain, and then you switch to sagittal, start midline, and then you sweep right, left. So you start, you know, with your corpus callosum, in your midline, and you sweep right, sweep left. You use a high frequency linear probe. You do the same, sweeping right, sweeping left. So it's not a difficult study. You know, just sometimes the babies move around on you a little bit. Just make sure you have good contact. Try and anchor yourself when you're scanning. I like to hold the probe very low, kind of use my other fingers to anchor myself on the baby's head and give myself, you know, a good window to just angle maneuver. Just make sure that your falx, your interhemispheric fissure, when you're in coronal view, is midline, right down the middle of the screen, so the brain looks symmetric on either side. Because if you're off axis and off angle, you can create the appearance of asymmetry of the ventricles because you're slicing them at off angles. So you want to make sure that, you know, your interhemispheric fissure is exactly midline in your coronal view. And you begin to sweep, you know, anterior to posterior. Make sure your notch is also pointing to the baby's right ear. So you don't want your notch, you know, pointing in the wrong direction. So in your coronal view, your notch is towards the baby's right ear. So it's easier when, you know, when the baby's facing, you know, face up. So then, like, you know, the notch is towards you, you'll be on the baby's right, you know, patient's right side. And then when you switch in your sagittal views, the notch is pointed towards the nose. So again, if a baby does develop a bleed, typically we follow with serial ultrasounds. So they'll do them every 7 days. Because again, these bleeds, you know, they develop slowly over time. So I've had cases, you know, where babies, you know, have a mild grade 1. It's not even, or maybe even normal when we do the initial ultrasound. And then we come back a week later and the bleed has progressed, you know, to grade 2 or grade 3. So these bleeds develop slowly over time. And then they have to be followed and monitored. Any questions about anything? So I uploaded like the first part of quiz 3. Quiz 3 isn't going to be due till later, so we got a little more time. I'm just going to upload the second part today. That's going to be for was it the neonate hips and spine. So those 2 chapters are a little bit shorter. I know this one was like a lot of labeling brain parts, and which is very tedious. And a lot of which you're not necessarily going to be required to recognize when you're doing these ultrasounds, but it's good knowledge.
Did anybody find on the quiz the one labeling? It was like number 6.
No, that's
the second part.
That's the only one I couldn't.
No.
I literally just looked that up on Google. Like I looked up
I did too.
axial it was axial view
Basal ganglia.
And I just like kept going through pictures. There was only the one in between the anterior horn of the lateral ventricle I wasn't sure of, but I just put that it was this the septum pellucidum, because I think that's what separates them.
Yes.
Okay. Yeah, I Googled it also because it is not in the book.
Yeah, no, I was looking
At
for
all.
it, but I just like kept going through the images on Google and tried to piece it together.
Yeah, I did the same. Okay.
Okay.
I was just wondering if maybe somebody else found it in another book.
All right. All right, guys, so I'll see you back at 10 o'clock. So we're gonna start into abdominal stuff next class. So we're gonna do get into abdominal stuff. Lab, we can finish up anyone who needs to finish up doing reflux. So I had you guys saving your images. So it's for the reflex comp, just the one leg is fine. And then I wanted to get us into doing some abdominal scanning, and we'll work on doing a full complete abdomen, you know, from A to Z. And that's gonna be your final comp for that class.
All right,
I'll see you.
thank you.
Thank you.